In this presentation, I will discuss the nursing care of the pediatric client with cleft lip, cleft palate. Theory indicates that cleft lip with or without cleft palate is the most commonly occurring craniofacial abnormality among newborns. The incidence of cleft lip is more common in boys, whereas cleft palate is more common in girls. Now let's take a moment to understand what has happened during the craniofacial development of the fetus with these defects. Cleft lip results from incomplete fusion of the embryonic structures that surrounds the oral cavity. It is theorized that this process should occur during the 6th week of gestation. In cleft palate, there is a failure of the primary and secondary palatal plates to fuse during embryonic development. This process usually occurs during the 7th to 12th week of gestational development. As you note on the image being shown, consistent with those in the text, there are variations in the clefts of the lip from just a notch in the vermilion border of the lip to a unilateral cleft in the lip and to a more extensive bilateral cleft in the lip. The more extensive the cleft, the more involvement there is with the position of the nose and dental formation. As in cleft lip, there are variations in the degree of involvement with cleft palate that extend from involving only the soft palate to involving the hard palate. The cleft may involve only the midline of the palate or extend to the nostril on both sides. Now, the etiology can be identified from a number of causative factors. According to research, a gene that plays a major role in cleft lip and cleft palate has been identified. The findings could improve genetic counseling and potentially lead to improved treatment for the birth defect. Use of anticonvulsant medications and smoking during pregnancy are implicated as well. A number of other factors have also been identified and linked to the development of the cleft lip and cleft palate. As we turn our attention to the diagnosis of these defects, the identification of a cleft lip is obvious and can be easily made upon delivery. And of course, the newborn assessment includes inspection of the hard and soft palates, which could detect a cleft palate if present. Also, prenatal diagnosis of cleft lip can be done through ultrasound. It is often theorized that any child born with a defect should be examined to see if it is part of a syndrome, as other anomalies could also be present. Now, what reaction is the parent likely to demonstrate when seeing this infant for the first time? The impact on the family following the birth of a child with either a cleft lip or cleft palate or a combination of both can be devastating, and we can readily anticipate that the first question from distraught parents will be, "How did this happen to my baby?" To avoid an automatic response of saying, "I don't know, you need to talk to the doctor," we must be knowledgeable of the etiological factors as previously presented, but it is also important to address the emotional needs of the parents. It is important to know that the parents are grieving the loss of a perfect baby, and their emotions are more than likely very high. Now, how should the nurse handle the parents' reactions? Okay, that's a hint that you need to review communication skills if you are not so strong in using therapeutic techniques. Think of all of the possible ways in which you can promote the bonding process, such as encouraging the parents to verbalize fears and concerns, encouraging touching and holding of the infant. Let them see you do so in your contact with the infant as well. Point out positive attributes of the infant and show before and after pictures of other children with these defects. Depending on the time for surgery, routine care must be taught to the parents before discharge, since these infants will remain at home until it is time for surgical intervention. For example, those who will have cleft lip repair should become accustomed to being placed in a supine position, whereas children who will have cleft palate repairs should become accustomed to remaining on their abdomen. The parents can also accustom the infant to being placed in restraints before surgery so that they are not upset when applied following the surgery. Whatever type of feeding technique will be used after surgery should also be practiced at home so that the infant becomes accustomed to it. Take a moment and look at the image of this infant. What challenges can you anticipate there will be in the care of this infant? Because of the difficulty in the infant's ability to swallow normally, secretions pool in the nasopharynx and might be aspirated. As well, fluids given to the infant can go through the open palate and out the nose, which can lead to possible aspiration. Now, if you were to map out a plan that focuses on preventing aspiration of secretions and providing adequate nutrition, what would that plan include? The infant usually is unable to suck adequately on a standard nipple due to the inability to create the vacuum around the nipple. Soft nipples with larger holes and longer spouts are used to provide formula while enhancing development of the muscles used for sucking, swallowing, and speech. Breastfeeding, just as bottle feeding, may be difficult, but is possible, and there are advantages to doing so. But if the mother is unable to do so, regardless of the feeding method used, the mother should begin to feed the infant as soon as possible before discharge, since an adequate fluid intake is necessary to prevent dehydration. The mother should be given clear instructions on how to position and feed the infant, including observations of the infant's tolerance to feeding. Surgical correction of the lip defect is done very early, usually when the infant is 1 or 2 months of age, as long as the infant weighs at least 10 pounds and without any other compromises. Of course, an early repair helps the infant to experience the pleasure of sucking as soon as possible, as well as with parental bonding. When the child is ready for the surgery, The nurse will complete a surgical checklist and correctly administer any pre-op medication ordered, as well as monitor for side effects. Any necessary explanations as to the action of the prescribed medications are made known to the parents. What you're seeing on the image now is just a representation as to how the surgeon repairs a cleft lip. Repair of the cleft lip involves one of several staggered or Z-shaped suture lines to minimize notching of the lip because of retraction of scar tissue. Of course, the results are better if the defect involves only the vermilion border, or as shown, a unilateral defect. The postoperative nursing care is focused on care of the surgical site, and I will talk about this shortly. Several types of restraints are used depending on the age of the child. Shown are elbow and wrist restraints, and for an older child, a jacket restraint may be used. Some surgeons may not advocate using restraints. However, you still need to know that it is only a preference to not use them, and this theory still presents documentation to support the use of restraints following a cleft lip repair to prevent the infant from injuring the suture line. Restraints are also used following a cleft palate repair. Now, anytime a device such as a restraint has been applied to a limb, the nurse has the responsibility of making certain that circulation has not been impaired. Therefore, make sure that you follow through with the appropriate measures to provide relief from the restrictions. However, I must caution you, and this is a big caution, do not become careless and allow the infant to injure the surgical site. A problem arises when you, yes you the nurse, has to explain to a parent or the surgeon how you took the restraints off so that the infant could exercise his arms and he tore away the sutures. Immediately after surgery, the incision is secured with either an adhesive butterfly or a Logan bow. This image shows an infant with a Logan bow applied, which is a metal device bent in the shape of an arc and taped to both cheeks to protect a repaired cleft lip. This device prevents tension on the upper lip and promotes healing with less chance of noticeable scarring. By the way, try and anticipate the infant's needs to help minimize tension on the lip, especially from irritation and crying. After surgery for cleft lip, the infant is kept on NPO status until awake and alert, and then he begins clear liquids, then progresses to breast or bottle feeding. The suture line is cleaned meticulously according to policy and instructions of the surgeon. Look up the word meticulously if you are uncertain of the manner in which this care should be done, so that you won't just grab a washcloth and start scrubbing away formula or drainage around the mouth. This practice could loosen the sutures. Now, some institutions may have kits that are used with everything that you need in the care of the surgical site, including maybe sterile cotton-tipped applicators. The surgical site is cleansed with normal saline and a layer of an antibiotic ointment is thinly applied. Nothing hard or sharp must be allowed to come in contact with the suture line. Position the infant to prevent him from rubbing the surgical site on the bed linen and in a position to maintain clearance of the airway. A successful surgical experience will be evidenced by the child's appearance, and this occurs when the surgical site has remained clean, free from crusting, and the suture line remained intact and has healed well. With such improvements in the surgical techniques, deformities related to scar retraction have been minimized, but of course there is less optimum cosmetic results with more severe defects. Now, it does not rule out future or further revisions being required in an older child. The timing for surgical correction of cleft palate is controversial, varying from the neonatal period to early toddlerhood. However, most research supports that the surgery be done before the child develops faulty speech habits. The chart on the screen identifies some of the essential aspects of the care of the child following surgery for a cleft palate. Because of the edema that occurs after cleft palate surgery and the adjustment to learning to breathe through the nose, observe the child closely in the immediate post-operative period for respiratory distress. Now, usually appropriate positioning and the use of a mist tent can resolve difficulty with breathing, but if signs of further respiratory distress occurs, it should be reported immediately. The arms are restrained in order to prevent the child from putting fingers or small objects into the mouth and disrupting the suture line. The protection of the suture line should be stressed to the parents upon discharge, and this practice should continue until the surgeon okays the discontinuation. Now, a group of healthcare providers will examine the child periodically for long-term problems related to speech impairment, frequent ear infections, and possible hearing loss. Usually, orthodontists are needed to correct any malposition of the teeth. And some of the more difficult long-term problems related to the child's social adjustment must be addressed. Your text has a care plan that you should read very thoroughly. It will also cover some of the things that I have talked about, as well as give you additional insight into how to manage the care of a child with a cleft lip, cleft palate. So make sure that you are paying attention to the care plan as well as reading the content very thoroughly in your text.